Dr. Cesar J. Bravo. I'm the program director for the Virginia Tech Carilion Hand and Upper Extremity Fellowship. And we would like to provide an update of innovations in hand and upper extremity surgery and a lot of work that's going on here at Virginia Tech Carilion. One of the things when we talk about disruptive opportunity, there are those that challenge the status quo. And identifying disruptive opportunities requires a strategic mindset, a creative approach, and a willingness to experiment. One of the things is when we talk about disruptive technology or innovation, such as a term that's used to describe a new innovative techniques, such as like the iPhone when it came out in 2008, it changes the way we do things, which often include replacing older methods and systems. And this is, we can see when it came out in 2008 in Forbes, that disruptive technology, such as the iPhone, has referred. And there's a lot of doubters at that time. We think that artificial intelligence is one of those disruptive technologies that has been increasingly being used to support clinical decision making and planning in orthopedic surgery and also in hand and upper extremity surgery. And what we're going to do, we're going to focus on AI, 3D planning, robotics within the hand and upper extremity. And we think this eventually is going to elevate our hand and upper extremity care that we provide our patients. We're able to apply these technology advancements and impact our patient outcomes, and we'll be able to explore some future directions. Just understanding about AI, its definition, it's an umbrella term describing a computer or software capable of performing tasks that traditionally require human intelligence. Artificial intelligence aims to simulate human thought processes and activities, basically ultimately solving many problems in a better, more efficient way than humans can. And one of the things is we can see here the subcategories of deep learning and convolutional neural network. With all these subcategories intersect is where we're talking and able to produce and facilitate areas of image recognition, text-based AI, and multimodal AI. For artificial intelligence in hand and upper extremity, it's largely attributed to the fact that with continual medical advances and digitization, clinical decision making has become more and more reliant on data. As the volume and complexity of the data sets grow, it is understandably difficult for physicians to manually discern meaningful patterns that guide diagnosis or treatment. And AI applications basically help us rapidly identify patterns from large data sets and are being developed to assist us in providing improvement in patient care and workload efficiency. And one of the things is, as we see with regards to AI, the applications will, especially used a lot in hand surgery, imaging interpretation, such as X-rays, CT, MRIs. We can use it for predictive modeling for outcomes of our patient and also help us in decision support of systems for diagnosis and treatment. Just a little bit about artificial intelligence in hand and upper extremity. The emerging tools such as ChatGPT 4.0, AI platforms that basically we can use in surgical education simulation. But like anything, there's always challenges and limitations, and these are ethical considerations, the data quality, as poor data coming in results in poor data coming out, and how we're going to apply these things into our clinical integration. Just a case example where hand surgery, most of the artificial intelligence advances we've seen are image-based fracture detection, which use deep learning algorithms such as what we mentioned, that convolutional neural networks. And this is a great comparative study that models, in a sense, our scaphoid fractures. And it was able to efficiently show that we were able to achieve accuracy and sensitivity and specificity similar to or better than expert clinicians in detecting distal radius and scaphoid fractures on radiographs. And this is the type of modification of practice where we're able to identify these scaphoid fractures here with improved accuracy just from plain films that further imaging such as an MRI or CT scan will basically remove out of the equation, and thus improve our diagnostic acumen with just plain films when we're not seeing it, and also diminish the cost of the general care we're providing the patient. As we move from artificial intelligence to 3D planning in the upper extremity, is one of the things that we found with 3D planning surgery, specifically in our shoulder replacement and our complex reconstructions, not only in addition to the elbow or forearm reconstruction, that we can use patient-specific anatomy using a CT or an MRI, virtual surgical rehearsal, and implant positioning. And we found, and this is where we're looking at our data here at Virginia Tech, that the outcomes increase accuracy and better visualization of deformity, especially when we're dealing with complex anatomy. Just a little bit of review as we're going to show some 3D modeling for total shoulder replacement. There's three types of shoulder replacement. One where we talk about the anatomic total shoulder, where we replace the humeral head and the glenoid together, and that's called the total shoulder arthroplasty, as we're doing like with like. We also talk about the shoulder hemiarthroplasty, which is a partial replacement, just the humeral side. And also one of the things that we mentioned talk about is the reverse total shoulder arthroplasty, when we basically reverse the anatomy and place the ball on the socket side, and the humeral will place it at cup side. And this is usually when we have deficiency of rotator cuff, where it's not present and we're not able to carry out a standard shoulder replacement, or what is also referred to anatomic total shoulder. Currently here at Virginia Tech, we've been using since 2008. It's called blueprint planning. We don't have any conflicts of interest, but this does help us evaluate the glenoid morphology, rotator cuff pathology for preventive planning. And we use computer-assisted glenoid implantation, which has been shown significantly to improve accuracy and precision. Now, one of the things that we're currently using is called the shoulder ID for our reverse total shoulders, where we're able to implant a patient-specific base plate. We're able to match the implant bony deformity. It does not require glenoid reaming, which is preparing the base right here. And it maximizes base plate support. And we think that this, in a sense, will improve our outcome, as we're able to provide patient-specific instrumentation to the specific deformity that we're treating. One of the things that when we use this is, as our team, we're able to get a CT scan. This CT scan is uploaded to the cloud. We plan the surgery. It's brought into our institution, and that's when we implant. It's about a 6 to 8 week process, and currently now it's gone down to 4 to 6 weeks. But just so understanding the workflow, irrespective of which technology or implant from whichever company you end up using that provides this. And one of the things is we're able to plan the surgery in a virtual manner. And one of the things that we tend to see is we're able to model the deformity as we're moving around. We're able to, this is using the CT scan to actually view the deformity. And again, this is using the blueprint technology, but there are many other companies that provide similar planning methods to help the orthopedic surgeon with regards to the shoulder surgery. And as we're able to see the 3D deformity, we're able to kind of correlate that deformity, assess for removal of the portion, how's the glenoid going to look, how we're able to kind of go back and forth and adjust, look at the soft tissue envelope with regards to rotator cuff, as we're able to kind of do soft tissue windows, which is going to be shown here, as we're able to use these soft tissue windows when it's very dark. It's kind of, we can infer that there's attrition of the rotator cuff and there's fatty infiltration. Here is when we're using a model to kind of test our implants and kind of our positioning. We're able to see where we would want to have that implant. We use different parameters to kind of that we want to meet, and that's the guidance that we're using, and we're able to kind of see our screw length, our adjustments accordingly. and we're able to kind of go from there. And in a sense, this is also moving into the humeral side, where we're able to see the humerus when we do our cut. And again, trial implant. And last but not least, we're able to kind of test the area and basically see the parameters of the shoulder in itself when we're looking at areas of impingement, things that need to be addressed in surgery. And this is just a virtual range of motions that we're able to kind of locate. These are possible areas interpretively that we are using this technology to kind of predict things that we may expect in surgery. And again, from this, we're able to get patient-specific guides, which is what's being shown here. And this in itself is what helps us implant and that guide specifically to that anatomy as we plan virtually. And again, this is an example of the steps, and this is using the guide in itself. And right here, we're basically putting the guide. We remember that, and then this is a patient-specific implant. And this is just a little bit of an example of how it shows as we're able to modulate the implant and how it kind of fits. And we have this interpretively in a sterile fashion, and we use that for our case example. And here, usually, as we move forward, this is the specific case example here where this was used, and we were able to use that patient-specific instrumentation and provided and corrected the anatomy for our patient. In addition to this, we're also using 3D modeling, and this is a specific company that helps us achieve this, but there are many others. This is a Belgium-based company that's pioneered the 3D printing and modeling, and we're able to use it for complex fracture non-unions as well as tumor surgery. One of the things, this is for an example of a case where we had a medial clavicle non-union. We were able to kind of reconstruct using this technology and correct the deformity. And again, we were able to remodel and establish the length of her fractured collarbone, displaced collarbone, and we were able to use it and place it symmetric to the contralateral side, and we corrected the malunion. And the native corrected bone, it's the one that's not fractured, is in light blue, and the straw colored is the malunion, and this is how we're able to interpose and establish that length, and we were able to correct that deformity. In addition, also another case example for distal radius malunion, where we were able to use this technology. We're able to assess the deformity of the radius, both the straw colored is the malunited, and you can see the basically the positioning in a sense where the straw color is a native one, not deformed, but the blue one is the deformity. And you can see how much of the rotational as well as malalignment, both in the coronal and sagittal plane. And we were able to kind of use these guys, and using the contralateral extremity, we were able to plan the surgery effectively. In addition, we were able to use bone grafting that basically uses a specific dowel. And again, using the 3D technology, we were able to obtain this from the iliac crest in a precise manner. And we had the exact measurements in addition to our screw length and positioning. And this is once it was carried out. In addition to the reconstruction, we did do an open TFCC repair, which we had planned for that, and as you can see, we had a fairly excellent outcome reestablishing the rotational deformity and corrected it. We've used it for tumor surgery. This is a fairly complex tumor in the mid back where we had what we call as an osteochondroma in the posterior aspect, or the medial aspect of the scapula into the rib cage, and we were able to use our local 3D printing technology, our simulation center, and we planned this, and we're able to localize and basically exactly measure the tumor, where it was going to be, and we were able to precisely do limited, in a sense, not have to expose the whole scapula, but we were able to expose the tumor through limited windows. And actually, this is the actual tumor size, and you can see how it actually predicted the deformity and the tumor very precisely. One of the things that moves from the 3D modeling that now we're working in the future, we think, is robotics. And a robot is a mechanical device that can be programmed to perform one or more actions in response to one or more inputs. And one of the things that we're seeing, and this is robotic-enabled arthroplasty, and that's one of the things that in upper extremity it's coming in the near future. And we're able to, in addition to this, other things, it will be robot-assisted therapy, and as well as the benefits is sub-millimeter accuracy and customized patient plans and improving recovery. Again, like any new technology, there's benefits and disadvantages, as we can see here. But one of the things this is evolving, and eventually we feel that down 5, 10 years from now, this may be part of our armamentarium, and including in the patients that we treat, this will be part of our algorithm. Here's an example of using robotics as is being shown here in the picture on the left. We're doing and using haptic boundaries, which are the limits and borders communicated or perceived through sense of touch. This is courtesy of one of my colleagues, Dr. Joaquin Sanchez Sotelo from the Mayo Clinic in Rochester, Minnesota. You're able to see where the markings are produced here. The haptic boundaries are obtained for the glenoid preparation. And this in itself is communicated to the robot here on the right side, where we're able to kind of find those points, localize them, and then use the robotic arm to proceed with a specific and very precise implementation of preparing that glenoid for implantation of the implant arthroplasty. Future directions are vast. One of the things is the interoperability of AI, 3D robotics working together for precision and personalization and workflow. The new frontiers as the brain-machine learning interfaces, advancing simulation, point of care, 3D printing, and emerging evidence anticipated changes to surgical practice, such as we're seeing currently. And these language models using for documentation, case processing, and answering patient questions as well will be phenomenal. In summary, with innovations in hand and upper extremity surgery, we think the technology-driven transformation is fairly significant, using artificial intelligence to enhance diagnostic and decision-making and workflow efficiency. The 3D planning will provide personalized surgical guides, improve accuracy in patient education, and robotics will lead to precision in joint reconstruction and rehabilitation, enabling minimally invasive care. The clinical impact is of improved patient detection, customized implants, reduce operative time, blood loss, radiation exposure. But in the future directions integrate artificial intelligence, 3D modeling, robotics for a seamless surgical ecosystem. And again, the brain-machine interfaces and point-of-care 3D printing, meaning brain-computer interface, which is a direct communication and link between the brain's electrical activity and an external device, such as these commonly used in computer or robotic limbs. And this is an evolving surgical education and simulation platforms as we train future orthopedic surgeons, future hand and upper extremity surgeons. Thank you for your time. Hope you found this topic stimulating and interesting. And again, I'd like to appreciate my partners as a team effort is when we're able to accomplish all these things from our hand and upper extremity section. Thank you.